It starts as something easy to ignore, a heaviness in one leg that you chalk up to a long day on your feet, a dull ache in the calf that you assume is a muscle strain from the walk you took yesterday, a slight puffiness around the ankle that you attribute to the heat, or to sitting too long in the car, or simply to being 67 and having legs that get tired now in ways they did not at 45. So you rub it. You elevate it for the evening. You tell yourself it will be gone by morning. And sometimes it is. And sometimes, quietly, it is not a tired leg at all. It is a clot forming in one of the deep veins inside your leg, a few centimeters wide, sitting silently in a vessel that carries blood from your lower body back to your heart. And if that clot breaks free before you have recognized it for what it is, it travels through the right side of your heart and lodges in the blood vessels of your lungs. And at that point, the situation has changed completely. I want to be clear about something before we go any further. What I am about to share is not meant to make you afraid of every ache in your leg. Most leg discomfort in adults over 60 is exactly what it appears to be. Muscle fatigue, arthritis, varicose vein discomfort, positional stiffness. These are common, they are not dangerous. And the goal of this video is not to turn you into someone who rushes to an emergency room every time a calf aches. The goal is to give you a framework for knowing the difference. Because deep vein thrombosis, the blood clot that forms silently in the deep veins of the leg, has a pattern of symptoms that is genuinely distinguishable from ordinary leg discomfort once you know what to look for. In the difference between recognizing it and missing it, and in some cases be the difference between an outpatient course of anticoagulation and a pulmonary embolism. Before anything else, what I share in this video is educational information only. It is not medical advice. If you experience the specific symptoms I am going to describe, particularly sudden swelling in one leg, warmth, redness, or calf pain that is unexplained and persistent, please contact your healthcare provider promptly or go to an emergency department. Do not wait to see if it resolves on its own. That distinction matters, and I will tell you exactly why. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60. And the reason I want to make this video is that I have seen, more than once, someone describe a leg symptom in a routine appointment and have it turn out to be a DVT that had been present for days while the person had been managing it at home with elevation and ibuprofen. The symptom was there. The warning was there. The information to act on it was not. That information is what this video is going to give you. If this is your first time here, subscribe right now. Every week I bring you specific, grounded information about what your body is communicating after 60. Me jest trick long here. Let me start with what a deep vein thrombosis actually is, because the word clot is used so casually that most people do not have a clear picture of what is physically happening inside the leg when one forms. Your circulatory system has two distinct types of vessels. The arteries carry oxygenated blood from the heart outward to the body. The veins carry deoxygenated blood back from the body toward the heart, and then to the lungs for reoxygenation. In the legs, the veins run in two systems. The superficial system, just beneath the skin, is what you can see as the visible veins on the inner calf and thigh. The deep system runs alongside the major arteries, embedded deep in the muscle, and carries the larger proportion of blood returning from the lower limb. A deep vein thrombosis is a clot that forms in the deep system, not in a superficial vein, where a clot would be visible as a hard, tender cord under the skin and is generally not dangerous in the same way. A deep vein thrombosis forms in vessels that are invisible from the outside, that carry significant blood volume, and that communicate directly with the pulmonary circulation through the inferior vena cava and the right heart. The clot forms when three conditions are present simultaneously. The blood is flowing more slowly than normal. The blood itself is in a more coagulable state than normal, meaning it clots more readily, and the lining of the vein wall has been disrupted or inflamed. These three conditions were first described together in the 19th century by a German physician named Rudolf Virchow, and they are still taught today as Virchow's triad. All three can and do worsen with age. Blood flows more slowly in older adults because the calf muscle pump, the mechanism by which leg muscle contractions squeeze blood upward through the veins against gravity, is less powerful than it was at 40. Mobility decreases. Periods of sitting and inactivity become longer. And the venous valves that prevent backflow of blood in the legs become less competent, allowing blood to pool in the lower leg rather than moving steadily upward. Blood becomes more coagulable with age for several reasons. The clotting factors increase in concentration. Certain medications common in older adults, including hormone-based therapies, some antipsychotics, and chemotherapy agents, push the clotting balance toward thrombosis. Cancer, which becomes more prevalent with age, is one of the strongest known drivers of a hypercoagulable state. And dehydration, common in older adults because the thirst mechanism weakens, increases blood viscosity and makes clotting easier. The vein wall is more susceptible to disruption with age from minor trauma, from inflammation associated with chronic conditions, and from the cumulative wear on vascular tissue over decades. This is why deep vein thrombosis is far more common in adults over 60 than in younger people, and why the risk is not evenly distributed. An older adult who has recently had surgery, who is on several medications, who has limited mobility, who has had a recent illness or hospitalization, who is dehydrated, or who has any active cancer, carries a substantially higher clot risk than the general population. Understanding your own risk profile is part of understanding which leg symptoms deserve urgent attention. The most important single symptom of deep vein thrombosis in the leg is swelling that affects one leg but not the other. I want to dwell on that for a moment, because it is the feature that most reliably distinguishes a DVT from the other common causes of leg discomfort in adults over 60. When the heart or kidneys are not managing fluid well, both legs swell. When the weather is hot and circulation is sluggish from the heat, both legs tend to swell. When someone has been sitting on a long flight, both legs feel heavy. Bilateral swelling in both legs, is almost never a DVT. It is almost always a systemic fluid issue, as a DVT causes swelling in one leg, specifically in the leg where the clot has formed. And the reason is direct: the clot is physically obstructing the venous drainage from that limb. Blood is flowing in through the arteries, but the vein is partially blocked on its way back. Fluid accumulates in the tissue of the lower leg. The leg becomes visibly larger than the other. If you look at both legs side by side, one is noticeably fuller than the other, particularly in the calf and ankle. This one-sidedness is the most important diagnostic clue. If you notice that one leg is swollen and the other is not, and that swelling has appeared over hours to days, and is not explained by an obvious cause like a recent injury to that specific leg, that observation needs to be taken to a medical provider urgently. Accompanying the swelling, people with a DVT often describe a sensation of heaviness or tightness in the affected calf, as though the muscle is being compressed from inside. The calf may feel firm or dense to the touch compared to the other side, often a dull, deep ache that is different from a muscle cramp that it does not come and go with movement and does not resolve with rest. Persists. It does not respond to the usual things that relieve muscle pain. The skin over the affected area may become warm to the touch, reflecting the inflammatory response occurring in and around the vein. It may appear reddened or have a reddish-blue discoloration, again reflecting the vascular congestion below the skin surface. And in some cases, the superficial veins of the lower leg become more prominent and visible than usual because the deep system is blocked and blood is attempting to return through the superficial route instead. None of these individual features is pathognomonic, meaning none of them alone definitively diagnoses a DVT. That diagnosis requires imaging, specifically a venous duplex ultrasound, which visualizes the deep veins and can directly detect a clot. But the combination of these features in an adult over 60, with even modest risk factors, should prompt same-day evaluation. You're not a wait-and-see approach. Just not the same-day evaluation. You want to talk about the pulmonary embolism before we go further into prevention and practical guidance, because the reason DVT carries such serious weight is not the leg itself. It is what can happen when a portion of the clot breaks free. The deep veins of the leg connect through the femoral and iliac veins to the inferior vena cava, and from there to the right side of the heart, and from there directly to the pulmonary arteries, the vessels that supply blood to the lungs for oxygenation. This is the anatomical reality that makes a lower limb DVT a potentially life-threatening condition rather than simply a local vascular problem. When a portion of a clot in the deep veins of the leg detaches, it travels as a fragment, called an embolus, through exactly this pathway. It passes through the right heart and lodges in one of the pulmonary arteries or their branches. The lung tissue downstream of the obstruction is cut off from its blood supply. Gas exchange in that region fails, and depending on the size of the embolus and the proportion of pulmonary circulation it obstructs, the consequences range from significant to immediately life-threatening. A massive pulmonary embolism, one that obstructs a large proportion of the pulmonary circulation simultaneously, causes sudden, severe shortness of breath, a rapid drop in blood pressure, loss of consciousness, and cardiac arrest. These large events are often fatal. Smaller pulmonary emboli produce symptoms that can seem more ambiguous: sudden shortness of breath that appears without obvious cause, a sharp chest pain that worsens with breathing in, a rapid heart rate, coughing, or a sense of anxiety or impending doom that the person cannot explain. The key word in that last description is sudden. Sudden, unexplained shortness of breath, sudden chest pain, sudden rapid heartbeat. In an adult over 60, these symptoms appearing without warning, particularly in someone who has had leg discomfort in the preceding days or weeks, require emergency evaluation. Not a phone call to a nurse line, emergency evaluation. The management of a pulmonary embolism is time critical. Every hour of delay worsens the outcome. A study published in the European Heart Journal found that adults over 65 who experienced pulmonary embolism had a significantly higher mortality rate than younger adults, partly because the cardiopulmonary reserve to compensate for the obstruction is lower with age, and partly because the diagnosis was delayed in a significant proportion of cases because the symptoms were attributed to other causes. Shortness of breath attributed to heart failure, chest pain attributed to musculoskeletal causes, rapid heartbeat attributed to anxiety. The DVT itself does not always hurt badly enough to prompt urgent care. It is sometimes subtle enough to be dismissed, which is precisely why knowing what the symptom pattern looks like and what it can lead to if not evaluated is so important. Type in the comments right now if you have ever had leg swelling or pain that you dismissed for more than a day before having it evaluated. Not to generate worry, but because the number of people in those comments will show exactly how common the dismissal is, and how important it is that the information in this video reaches people before they need it. And share this video right now with one person in your life over 60 who you know tends to manage symptoms at home without seeking attention. You might be handing them information that matters. Let me talk about the specific circumstances in which deep vein thrombosis risk rises most significantly in adults over 60, because understanding your own risk context changes how seriously you should take leg symptoms. The highest risk period for DVT in older adults is in the weeks following surgery, particularly orthopedic surgery, including hip replacement, knee replacement, and spine procedures. During surgery, blood flow to the legs slows dramatically. The trauma to tissue activates the clotting system. The recovery period involves prolonged immobility. This combination is the most reliably thrombogenic situation an older adult can be in. It is why blood thinners are routinely prescribed after these procedures. If you have recently had surgery and you develop one-sided leg swelling or calf pain, do not wait to see if it improves. Contact your surgical team immediately. Extended immobility outside of a surgical context carries similar risk. A long-haul flight, particularly one lasting more than 4 to 6 hours. She had a long car journey with limited stops. A period of bed rest from illness. A week spent largely sedentary after an injury to a different part of the body. All of these allow blood to pool in the lower legs in a way that, in an adult over 60 with other risk factors, can initiate clot formation. Dehydration is an underappreciated contributor. When the body is underhydrated, blood becomes more concentrated. The ratio of cells and clotting proteins to fluid increases. The blood moves more slowly and is more prone to forming a clot in areas of already slow flow. In adults over 60, where the thirst mechanism is less sensitive and where diuretic medications are common, arriving at a sedentary period already mildly dehydrated creates a compounding risk. Certain medications increase DVT risk specifically. Hormone replacement therapy, tamoxifen, certain antipsychotics, thalidomide and its derivatives, and some chemotherapy agents. If you are on any of these medications and you develop leg symptoms, the medication context needs to be part of the conversation with your doctor. Inactive cancer, or a cancer diagnosis in the preceding months, dramatically elevates DVT risk through multiple mechanisms simultaneously: the hypercoagulable state that many cancers produce, the treatments involved, and the immobility that often accompanies illness. A DVT in the context of recent cancer diagnosis or treatment warrants particularly urgent evaluation and specific management. If you have subscribed to this channel, thank you for being part of this community. If you have not yet, tap that button now and ring the bell, because every week I bring you this level of specific, practical information about health after 60. I want to tell you about a patient I will call Edward, 72 years old. Retired engineer from Seattle, Washington. He came to me 4 days after returning from a long overseas flight, a journey that had taken close to 14 hours in the air, followed by several more hours in airports. He had noticed that his right calf had felt heavy and somewhat sore since the day after the flight. He had assumed it was the prolonged sitting. He had been walking around, trying to work it out. By the time he came to see me, 4 days in, his right calf was measurably larger than his left. The skin was warm. He described a persistent deep ache that had not resolved with walking, or with a course of ibuprofen he had started 2 days prior. I did not wait for additional information. I sent him directly for a venous duplex ultrasound the same afternoon. He had a proximal deep vein thrombosis, extending from the popliteal vein in the back of the knee up into the femoral vein in the thigh. A significant clot in a large bore vein with direct access to the pulmonary circulation. He was started on anticoagulation that evening. He did not develop a pulmonary embolism. Edward told me afterward, I thought it was just the flight. I told him it was the flight. The flight created exactly the conditions for a clot to form. What mattered was that you did not dismiss it for another 4 days. Because 4 more days of a clot of that size in that location, without treatment, carries a very real chance of an embolism. He had almost not come in. He had told his wife that morning that he would wait 1 more day to see if the leg improved. His wife had told him to stop managing it at home and go. She was right. Let me now talk about what you can do to reduce your risk of deep vein thrombosis, because prevention is both practical and meaningful. The single most effective preventive measure for DVT in adults over 60 is movement. Consistent, regular movement of the lower legs, which activates the calf muscle pump and drives venous return from the lower limb. Walking is the most straightforward form of this. Even short walks, 10 to 15 minutes, 2 or 3 times a day, significantly reduce the blood pooling that creates DVT risk in sedentary adults. When extended sitting is unavoidable, the mitigation is specific. On a long flight or car journey, get up and walk the aisle or stretch outside the car every 60 to 90 minutes. When that is not possible, perform calf raises while seated. Press the balls of your feet into the floor and lift your heels, then lower them. Repeat 20 times. Rotate your ankles in circles. Flex and extend your feet. These movements activate the calf pump and push blood upward through the venous system even without leaving your seat. They are not trivial. They are physiologically meaningful. Compression stockings, specifically graduated compression stockings that apply more pressure at the ankle than at the calf, support venous return and reduce the diameter of the veins, which reduces the tendency for blood to pool. For adults over 60 with any history of venous insufficiency, varicose veins, or DVT, wearing compression stockings during long periods of sitting is a genuinely evidence-based intervention. Hydration is protective. Maintaining adequate fluid intake through the day keeps blood viscosity lower and flow rates higher. In adults over 60, this means deliberate attention to hydration rather than waiting for thirst to signal the need. 6 to 8 cups of water daily, not caught up at the end of the day, distributed through the waking hours. For adults in the immediate post-surgical period, adherence to the anticoagulation protocol prescribed by the surgical team is not optional. It is the primary prevention strategy for a high-risk window. If you are uncertain about whether your post-operative anticoagulation has been adequate, ask directly. Ask your surgeon when your last dose was prescribed, when it ends, and whether any leg symptoms during the recovery period should prompt you to seek emergency evaluation rather than waiting for a scheduled follow-up. And for adults on any of the medications associated with elevated DVT risk, have an explicit conversation with your prescribing doctor about what symptoms would warrant urgent evaluation and whether any additional preventive measures are appropriate given your medication profile. Here is the framework I want you to use to distinguish the leg symptoms that warrant urgent evaluation from those that can be managed with rest and monitoring at home. Symptoms that warrant same-day evaluation, meaning contact your doctor or go to an urgent care or emergency department today, not tomorrow. One-sided leg swelling that is new and unexplained. Warmth or redness in a specific area of the lower leg. A persistent deep ache in the calf or behind the knee that does not follow the pattern of a typical muscle strain. Any combination of these 3 features, particularly in someone who has recently had surgery, a long period of immobility, or who is on a medication associated with elevated clot risk. Symptoms that warrant emergency evaluation immediately, meaning call emergency services or go to an emergency department right now. Sudden, unexplained shortness of breath. sharp chest pain that worsens when you breathe in, a rapid heart rate that appears without obvious cause. So, what did me mana sensen? Coughing up blood. A sense of severe anxiety, or that something is very wrong, particularly if any of these appear in someone who has also had recent leg symptoms. These two categories are different. The first is urgent, but allows for a same-day evaluation through normal medical channels in most cases. The second requires immediate emergency care, because the time window for effective intervention in a pulmonary embolism is short. I want to be direct about one more thing: the tendency to wait, the tendency to manage at home and see if it improves, the tendency to not want to cause a fuss or take up medical resources for something that might be nothing. This tendency, which is extremely common in adults over 60, and particularly in those who grew up in a time when stoicism was a virtue, is one of the most consistent factors I see in cases that arrived too late. It is non-invasive. It uses sound waves. It does not involve radiation or contrast agents, and it definitively tells you whether a clot is present. If you go and the result is negative, you have lost 30 minutes of your afternoon and gained complete reassurance. If you go and the result is positive, you have potentially prevented a pulmonary embolism. The calculation is not a difficult one. Here is what I want you to take away. Your legs should be roughly symmetrical in size, temperature, and comfort. When one leg diverges from that symmetry, particularly when it becomes swollen, warm, or persistently achy in a way that does not follow the pattern of ordinary muscle fatigue, that divergence is your body communicating something about the deep veins in that limb. The communication deserves a response. The risk of deep vein thrombosis is real. It is elevated after 60, and it is elevated further by the specific circumstances of surgery, immobility, dehydration, certain medications, and cancer. Knowing which of these circumstances applies to you changes how seriously you should take leg symptoms when they appear. Prevention is practical and grounded in simple daily behavior. Movement, hydration, compression when appropriate, and adherence to post-surgical anticoagulation protocols together meaningfully reduce the risk. None of these require special equipment or unusual discipline. They require awareness of why they matter. And the pulmonary embolism that follows an untreated DVT is a medical emergency with a narrow treatment window. Recognizing the early leg symptoms and acting on them early is the intervention that prevents it. Not a specialist. Not a complex treatment. Early recognition, early evaluation, early treatment. That sequence changes outcomes. You are not being dramatic when you have a swollen, warm, persistently achy calf evaluated the same day you notice it. You are being appropriate. You are applying exactly the level of attention that this symptom warrants. And if it turns out to be nothing, the peace of mind is worth the visit. Share this video with someone who tends to wait things out, who manages symptoms at home rather than seeking evaluation, who would say it is probably nothing when a leg has been swollen for 3 days. You might be giving them the reason to go in. And subscribe to this channel, because every single week I come here with one purpose: to give you the specific information that helps you recognize what your body is telling you, and to act on it before the window closes. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.